Good evening, Sandil.
Good evening, sir. Good evening.
Good evening.
Good evening, Sandal sir.
Sandil, you are muted. You can unmute yourself.
Sir, good evening, sir.
Good evening. Good evening, everyone.
Sir.
So I think around 220 people have already joined.
Yes, sir. Sir, President, sir, he will be joining in between, sir. Secretary, sir, is there, and you can start, sir.
Yeah, we'll start with the IMA prayer. Dr. Solomon is there.
Okay. May everybody, IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Thank you, sir.
Welcome.
Good evening, everyone, and warm welcome to our AMS 6th CME session. So, respected State President Dr. Sridhar sir, and all the senior leaders of IMA who will be joining with us soon. And our AMS team, Dr. Senthil, Dr. Ibrahim, Treasurer Dr. Salamajaya, thanks for joining us, and all the other leaders of IMA, and especially the speakers for today's session, Dr. Aarti, Dr. Namita Narayanan, and Dr. Suresh. So welcome all of you. So this is a sixth CME of IMA AMS Tamil Nadu this year. So to every delegate joining us today, a very hearty welcome to you. This session is on Ebola. As you all know, recently the government of India has issued a notification on Ebola and few other viral diseases. We thought we'll give an update about Ebola from our experts to all our IMA members. And so this is the reason we are here. So I'm thankful to all the three speakers who accepted our invite and to be with us to share their expertise and knowledge with our members. And a quick word on something close to my heart. So we have launched many fellowships since our taking over. So fourth fellowship. And now I have an announcement to make. Our hospital cornea retrieval training program in collaboration with Arvind Eye Care System across Tamil Nadu. So we're planning to, this session was launched by our state president during the North Zone AMS conference, planning to start the session soon. Those who are interested in taking the training on hospital cornea retrieval can contact our AMS office bearers, and we'll soon be initiating this in association with the Organ Donation Committee of IMA AMS. And a personal request to all of you, if you are not a member of the AMS wing, even though you have joined with us for many meetings, if you are not a member of AMS wing yet, please do join the AMS wing, and AMS is your academic home. So we have a lot of CMEs, fellowships, and conferences coming up. And another good news is you can apply for the AMS fellowship to be given during the national conference of AMS, which will be announced soon. So it will be a wonderful recognition of your academic commitment, and we encourage each one of you to consider. It is open only for AMS members, so it's essential that you join as a AMS member and get ratified before applying for that. So before I close, a small request. So please give us your feedback at the end of today's session, so that we can make our CMEs much better, and importantly, topics focus on your requirement in the coming months. So with these words, I welcome all of you. I can see our immediate past president, Dr. Sengatuvan, Secretary, Dr. Dravya Mohan, and many other leaders. Welcome all of you. And with these words, I hand over the proceedings to our secretary. Over to you.
Yes, sir. Thank you, sir. Solomon, sir. Sir,
Dr. Dravya is here, Dravya Mohan, and also our immediate past president, Dr. Sengatuvan is.
First,
Yes.
sir, Sengatuvan sir, best சொல்லுங்க sir.
Yes, sir. Sir, now I request our immediate past president, Dr. Sengatuvan sir, to give us words of wisdom regarding this CME.
Thank you. Thank
Welcome
you,
you, sir.
Dr. Sindil. Respected President Dr. Sridhar, President-elect Dr. A.K. Ravikumar, NRTR Tyagarajan, Secretary Dr. Dravya Mohan, Finance Secretary Solomon Jaya, and Academic AMS Chairman Dr. Nirmal Frederick, Secretary Dr. Sendil, and the teachers of the day today. Thank you for giving this opportunity to be with you this seminar. I'm really very happy that Ebola virus is an important one, recent topic, and central government and our IMA headquarters is also giving importance to have the latest knowledge about the Ebola virus, and also the test needed for the things, and febrile fat test, recent fat test for what are all the things to be done for the febrile fever. So with these few words, thank you for giving this opportunity. Thank you. Over to Dr. Sendil.
Thank you, sir. Now I request our State Secretary, Dr. Dravya Mohan sir, to give us felicitations.
Good afternoon all. Greetings from Indian Medical and Tamil Nadu State Branch. On behalf of the Tamil Nadu State Branch, it gives me immense pleasure to participate in this AMS CME program. I'm very happy to congratulate the AMS team for conducting the 6th CME in an excellent way. For every CME topic, they had chosen topic of the current month, what is happening there. So I also welcome immediate past President Dr. Sengatuvan sir, Dr. Ravikumar sir, Dr. Tyagarajan, Solomon Jaya, and the AMS national team headed by Venkatachalapati sir, Amudan, Sairam, and state chapter like Nirmal Frederick sir, Sendil, and Mohammad Ibrahim. As you all know, we are happy to provide this important academic update to our members. Ebola, though not a major public health concern in our region at present, reminds us of the importance of the vigilance, early diagnosis, infection control, and preparedness in tackling emergency infectious diseases. As a part of the continuous medical education, and I'm confident that today's deliberation will enrich our knowledge and strengthen our clinical practice. I take this opportunity to thank the three speakers of this evening, Dr. Aarti, the microbiologist from SIMS Hospital, Dr. Namita Narayan, the pediatrician, and Suresh Kumar, the infectious disease specialist, who are going to enlighten us on the topic Ebola virus fever and its management. And once again, thank the opportunity and for the participation in this valuable contribution. Thank you, sir. Thank you. Sir,
Thank you, sir. Yes, sir.
Sir.
Yes, sir. Now I request our President-elect Dr. NRT Tyagarajan sir to give us felicitations.
Good afternoon. Thanks, Sendil.
Again, as usual, every month the current irukanga, the AMS, the entire team from AMS, lovely topic and very good faculty, Dr. Aarti, Dr. Namita, and Dr. Suresh. And currently, on a personal level, Ebola pati இன்னும் படிச்சே பார்க்கல. But glad that you brought it up. And after the advisory from the government concerning Ebola, I think we need to all be aware of what's happening and how best to go forward in this. Thank you for this lovely topics, lovely work as usual by the AMS wing of IMA Tamil Nadu. Thank you again and all the very best, and thanks for this lovely meeting. And thanks to the speakers again for taking part and guiding us in this. Thank you, sir.
Thank you, sir. Our President-elect, Dr. A.K. Ravikumar sir, is traveling now and he is not having a proper network there. So he has conveyed his wishes to the CME. So now we will proceed with the CME. Nirmal sir, can we start, sir?
Yes, please.
Yes, sir.
Yeah, you
Okay.
can start with the first speaker.
Yes, sir. Now I request Dr. Aarti, the first speaker of the day, to start the session. So Dr. Aarti is a microbiologist and she is a consultant and head microbiology department in SRM Institute of Medical Sciences. Worked under Dr. Sujata Chandrasekharan, MD, and Dr. Rajkumar Krishnamurthy, PhD in microbiology, for the past 11 years. I request you to take over the session, madam. Kindly proceed.
Good evening, everybody. I'll just share the.
Meanwhile, our president is held up in the meeting regarding insurance, and sir will be joining shortly.
I'm not able to share the screen.
Madam,
You can make her co-host, Sandil. Make all the three speakers co-host.
I think you are a co-host already, madam. Madam, your ID is Dr. B.
Yeah.
Aarti, correct?
Yeah,
So already you are a co-host, madam. You can share, madam.
No, only one host can share it. Just.
No, madam, multiple co-hosts can share.
Are you able to see the screen?
Not yet, madam.
Yes, now only it is coming.
Yes.
Yeah. So is it visible now?
Yes.
Yes, madam. Visible, you can make it
Full screen.
maximize the screen. Yes. Yes. Okay.
Yeah. So hope I'm audible. Yeah.
Yes.
Yeah.
Yes, madam. Loud and clear.
Yeah. Thank you. So first of all, I'd like to thank everybody for giving me this opportunity. So I'm humbled by this. So I'll try to do my justice to whatever knowledge is available, and hopefully it is useful for everybody. So what do we need to know about Ebola as a disease? Because this is new to us. So what do we need? How do we suspect and how do we confirm? So how did this all start? So on 5th May, WHO was alerted of a high mortality illness from the Democratic Republic of Congo, following which WHO entered and they did some analysis and the diagnosis, and finally they found out Bundibugyo virus, which is a type of Ebola virus in 8 of the 13 suspected samples. Then after a couple of days, more cases started pouring in, and finally WHO declared it as a public health emergency of international concern, following which even CDC also declared the same. So what is Ebola virus? It is just a single stranded negative sense RNA particle. So what are the types that we need to know? Just a basic on the types before we go into the clinical details. So Ebola virus is the commonest. Ebola virus is Ortho Ebola virus, Zairens, and then Sudanese, and then Bundybujonins. The last one is the one which we are having an outbreak now. Now, going through the past history, what about Ebola? Why are we concerned about it now? What has happened in the past? So we'll just go through the history of the past. I've just taken the outbreaks which occurred in Africa, which has crossed 100 numbers. So this virus was there, is been reported since 1976 on and off, causing outbreaks. The first one is caused by Zairens. The second one, 1976, again by Sudanans. So following which, the graph below shows the case fatality rates. Now look at the case fatality rates. In 1976, it was 88%. And in again 53%. Again 81%. So this is the case fatality rate. As we go towards the end, what we observe is the case fatality on and off is high, up to 88 to 70%. Now, when we go after 2010, there was one major outbreak called West African epidemic, where the number of cases shooted up to 28,610. And that was a huge number for the country to handle. And again, this was caused by Ortho Ebola virus, Zairens. And the case fatality was 39%. So this is the case fatality rate, the one below. And finally, what we are facing now is Ortho Ebola virus, Bundybuji. So this has a case fatality. So far, I have taken only the confirmed cases. So though the suspected cases are more, so far the confirmed cases on June 2nd from the CDC is 369 cases with a case fatality of 17%. So significantly, the case fatality is low this time. However, we need to see how the epidemic progresses. Now, when you see when you just go through the graph of the case fatality of how the Ebola virus behaves, the 80%, 70% case fatality are mostly due to the Ortho Ebola virus, the Zairens. That particular strain caused the highest fatality rate. And when you go through the ones causing the lower fatality rate, it has been Sudanans and the Bundybuji. And this time the fatality rates are significantly low, which is a good news for us. Maybe the IPC practices are good, and we know more about the virus now, so we are better at handling it. So more about the strain. So far the mortality expected is 30%. The problem here is we don't have any approved treatment or vaccine. So this is the overall outbreaks, like over the past 50 years, whatever has happened in multiple areas of the Africa, a detail on a geographic map of it. And when you come to this particular Ebola virus, it is only Ituri, this is the province, the Ituri province, which is marked in red color in the Democratic Republic of Congo and the adjoining area of Uganda. Now, going through the natural cycle of the virus. So it maintains two life cycles. One is the enzootic cycle, which is on the left side, that is maintained in bats. Mainly it is fruit bats which are involved, and these they are part of it forms a natural habitat of the bat. The bats maintain the virus. So how does it get to the human? First, the bat, probably whatever fruits it eats or the leftover food, when it carries the virus, is in the saliva of the bat, and the leftover food, when it is had by other animals like apes, chimps, and antelopes and other animals, then they get infected. There are huge outbreaks in these animals which do cause symptoms for them, and there is a huge population washout among the apes, chimps observed in forests. Following that, generally it comes to the human. Rarely the bat can transmit to the humans directly, but this is a rare phenomenon. Now, so this is the same thing as explained in another picture. So the virus is maintained in bats. So bats to human transmission is rare, but bats infects the non-human primates. So that is a major part of the transmission, following which man, when they get into touch with the infected, dead or sick animals in the forest, during deforestation or taking care of the animals or part of the all these things, then they get the infection, and human to human transmission is possible after the symptoms develop. So this is how it causes outbreaks then and there after a few years. Now this is in Africa, so they eat bats. This is called bush meat in bats. Probably this is one of the reason why in Africa they keep getting outbreaks, maybe so. But being a poor country, I think this is unavoidable. But now the bush meat is banned in Africa as of now because of the huge outbreak that it is causing. Now, human to human, how does human transmit to the other human? What happens when the human gets the disease? There is an incubation period of 2 to 21 days before the actual symptoms develop. So the people cannot transmit the disease before they have symptoms. So there's nothing to worry as long as the patient is asymptomatic, though they may have a contact with the Ebola patient. Before they have symptoms, they need to be quarantined, but they cannot infect others. But after they become, after they start developing the symptoms, they become infectious. So how do they transmit? One is by direct contact. So direct contact, that is direct contact with the secretions, body, blood fluid to the mucous membrane of the non-infected person. Then the disease can be transmitted, or a broken skin or abrasion in the non-infected person, the disease can get transmitted, or through fomites, the things and the surfaces, the environment, the things used by the sick people can get contaminated with the virus can stay alive and then transmit the infection. Droplet infection, is it a possibility? Yes, when the patient is extremely sick or has extreme lung findings, which happens towards the end when there is a multi-organ dysfunction. But usually it is only direct contact and fomite transfer. Now, why are we so bothered about the infection? About this infection is, one is there is no treatment. One is the infectious dose is very less. That is only 10 virus particles are enough. And as I told, the incubation period is from 2 to 21 days. And communicability, that is the ability to cause infection to others, comes after the onset of symptoms. This can go up to like 21 days is the norm. Rarely in semen for some patients, the virus is known to persist, which tells that it has a risk of transmission. Now, it belongs to a group of pathogen called dangerous risk group 4 pathogen. Now, what is this dangerous risk group 4? So it is divided. The pathogens are divided into risk 1 to 4. So risk group 4 is the pathogen with the highest lethality and highest mortality, which can be transmitted to the others, and which has a potential of an epidemic. So that is why this has to be handled very carefully. Now, there is no proper monoclonal antibody for this particular strain and no licensed vaccine for this group. Whereas the other virus like Xyrens and Sudanens, Xyrens is the one with the highest mortality. So this has some vaccines in development which is known to give some protection, and some monoclonal antibody which has been developed because it had caused frequent outbreaks in the past. The Sudan virus and Bundibugyo virus, we don't have any promising tools as of now. No vaccines and no therapeutics, and everything is in the trial mode. What is the risk categorization? What does the Indian guidelines tell us now to all of us? This is very important. So as of now, the passengers coming from Ebola affected country have to be divided based on the symptoms that they have. They can be from the Congo or from Uganda. So if they have no symptom and no history of contact with an Ebola patient, they belong to category 1. And for them, they just need self-monitoring at home for 21 days and daily reporting to the state and district hospitals concerned. Now, if they have no symptom, again, there is a contact history. They belong to the category 2. So here, they should be quarantined at a designated facility of the government for 21 days. Till they have to be observed for the symptoms, whether they are developing, and then they have to be discharged. And the last one, the dangerous one, that is if symptoms are present, they belong to category 3. So we need these are called suspected cases. So we need isolation and testing at the designated isolation facility. So as of now, NIV under ICMR has the testing facility. NIV Pune is testing for Ebola. No other centers are authorized to test Ebola. So what are the signs and symptoms? So when you go through the signs and symptoms, there are 2 phases. One is the dry phase and the wet phase. Dry phase is when the patient develops fever, malaise, muscle pain, a general weakness, a mild diarrhea, which is common as for all viral diseases. And slowly by the second week, some patients will start developing a rash, a maculopapular rash, which will be over the trunk and the arms. So this is what we have to look for as a clinician. So the fever followed by the rash. The rash is typically hemorrhagic and necrotic rash, and slowly the patient may develop bleeding diastasis like petechiae, ecchymosis, and bloody vomit. So all these and slowly followed by a bloody diarrhea. So the initial symptoms, generally some patients have diarrhea of up to 10 liters per day. So the initial part during the fever. So that is when we can confuse that with cholera and other diseases. So the skin rash, the typical skin rash, so this is the appearance, the hemorrhagic. They are hemorrhagic first, they develop blisters, slowly there is bleeding into the blisters. And when there is an IV line, so when there's an IV line, that can be oozing from the IV line. So all these are the symptoms where you should think about Ebola. And finally, the patient, that is when you need to suspect Ebola and go for the further diagnosis. Now labs, what about the general labs testing? So what can the patient have? The patient can present with leukopenia. A typical symptom is bradycardia. The fever will often be associated with bradycardia like a typhoid. So the bloods can show leukopenia, especially lymphopenia, especially the limbs will be low, followed by an elevated leukocyte count. So a serial testing is required of the total counts. Then thrombocytopenia up to 50,000, it can go. The platelet count can go up to 50,000. And transaminase elevation, because the liver tends to develop multifocal hepatic necrosis. So there is an elevation of transaminases. So LFT is very important for these patients. And creatinine kinase also should be monitored, because sometimes the patients may go in for severe skeletal muscle injury due to the virus and end up in rhabdomyolysis, following which the patient can develop a renal injury. So there can be 3 reasons to renal injury. One is rhabdomyolysis, one is a severe diarrhea which can lead to AKI, or a direct injury by the virus. So a basic LFT and RFT along with the counts is very important in seeing the progress of such suspected cases. Electrolyte abnormalities like hyponatremia is often associated because of the diarrhea, hypokalemia, hyperkalemia, which often leads to arrhythmias because of the hypomagnesemia and everything. So all these electrolyte abnormalities are also associated with the disease as the disease progresses. Now, what are the other mimickers? As we go through the lab, we need to know what other diseases we need to differentiate. Being a tropical country, so malaria is one which the early stages can present similar to the Ebola, the early signs. Then typhoid fever, because a striking bradycardia, which is common for both, and shigellosis, the bloody diarrhea. The patient can also develop meningoencephalitis like symptoms with a stiff neck. So it is often confused with meningitis. Another dengue and other viral hemorrhagic fevers. So we need to parallelly evaluate these, rule out these diseases in our country before we arrive at a parallelly. These also may turn out to be positive. So whom do you suspect? Like these are the general labs and other tests. Now, whom do you suspect? Who are the suspects? Suspect case. So now we have a definition for suspect case, a probable case, and a confirmed case. A suspect case is a person who has traveled to the affected area in the past and is now having symptoms, fever with acute symptoms and the signs of hemorrhage. A probable case is the one who has a definite contact with a confirmed case. Now, what is a confirmed case? He or she is diagnosed, is that the Ebola specific test is done by the laboratory and they have confirmed it as a Ebola. So this differentiation is very important because for the handling of the patient depends on this. So suspect case is one with a history of travel to the affected area with symptoms. So all this the criteria is based only for symptomatic patients. We are dividing them. One with history of travel, one with history of contact, and one is a confirmed case. So this is also very important. Now, why do we need to do the Ebola specific testing? That is apart from the routine labs, Ebola specific PCRs or what other test we'll be going to. So there are only two indications. First is for diagnosis, as we have discussed, and the next one will be for discharge of the patient following treatment. So when can we allow them into the community so that they don't cause a further outbreak? So these are the two indications. Now we'll go to the first one. So in diagnosis for living patients when they are a suspected or a probable case. Now suspected is travel history from the region, that is Democratic Republic of Congo or Uganda, with symptoms but they don't have any contact history. A probable case is one who has had contact with the Ebola case with symptoms. Now in these patients we have to do the test. What if your test is negative? So it has turned negative, but still you don't know. Now you have to check. Can we declare them with one test? Now we need to look into when the test was done from the start of the symptoms. That is, you identify the onset of the symptom, time of onset, and if the test was done within 72 hours, then you need to repeat the test once again after 72 hours. That is 3 days after symptom onset, a test has to be done. This is a mandate before declaring them as negative. Suppose you find a patient who's tested after 3 to 4 days after symptom onset and is negative, we can declare them as negative. So this is a very important slide. So first, when the test is done is very important from the start of the symptoms. So if the test is done less than 72 hours, we need to do at least one test after 72 hours to clear them of infection. Now, discharge. Prior to discharging a confirmed patient at a treatment center, 2 negative tests should be there from blood samples and they should be taken at least 48 hours apart. So this situation practically as of now we are not facing. So maybe we need to know how it is diagnosed. That is more important. The first indication is more important for India as of now. So can we screen all the contacts of a suspected case? Suppose a person has had contact but has not developed any symptoms. Can we screen them just to be sure they don't transmit the disease? No. Diagnostic testing should be never done on an asymptomatic individual, though they may have had contact with a suspected case or a confirmed case. Diagnostic testing should never be performed because it can give a false sense of security if it is negative. You need to have a mandatory 21-day surveillance period, isolation period before we release before the negative result is. So negative results are not alone sufficient. The quarantine period is very important in asymptomatic people. So never test on asymptomatics. So you can quarantine them for 21 days. So that is more important. So what are the tests that are available for confirmation? So RT-PCR, that is reverse transcriptase polymerase chain reaction. I think everybody is aware of this because with COVID, this test has become very comfortable to all of us. It comes under a group of tests called NAT, nucleic acid amplification test. It's a kind of NAT. PCR is a kind of NAT. Now, what are the other tests? So we can do ELISA tests, that is antibodies, IgM and IgG, and antigen capture detection tests, and whole genome sequencing. Antigen capture detection tests are nothing but the rapid test, just like the pregnancy test, which we do a card test. And whole genome sequencing is to identify the genomic changes. That is for epidemiological purpose. Now, let us go to the test which we need to do. So, molecular test is done by real-time PCR in clinical specimen. When we look into the cycle threshold, it varies from kit to kit. So, it depends on what kit is used. The cycle threshold may vary. And serology, presence of Ebola IgM antibodies, that is detected. Then IgG antibodies is detected, and you can take a paired sera. Basically, the first sera is taken within the first week of illness, and again you take it after 2 to 3 weeks, and you find a raise in titer. A paired serum raise in titer is an indirect evidence that the patient may have had Ebola. Now, lab testing requires strict infection control protocols to manage the significant hazard. And following the diagnostic and follow-up, what are the samples we can do? That is more important. We know that, so as we go back to the tests, it is RT-PCR. Now it is serology, that is IgM and IgG, paired sera for IgG, and antigen capture detection test, and whole genome sequencing. So when we go to the molecular test, so what sample can we take? In a living patient, the confirmation is either through blood or plasma. Rarely oral buccal swabbing, which is not preferred, it is not recommended generally, but it is done for deceased patient. So oral and buccal swabbing is done for deceased patient because we have to take a lot of precautions for burying. So these are done even for deceased patients if they are not tested before when they were alive. So for a living patient, it is EDTA, blood or plasma. Now, during the acute phase, once it is confirmed, so we can go for other samples, like you can repeat the test on the same blood to look for the viral counts and other things. These are all for research purposes. We can take the CSF to understand how the disease spreads to the CSF, urine, breast milk, semen. These are all done only for research purposes because we need to understand how the disease spreads, where it persists, which are all the fluids it persists. Otherwise, for a routine testing, it's only blood or plasma. Now, diagnostic testing, as I told you, NAT, which is a PCR is a kind of NAT. So we can do it for a deceased patient. We can take a swab from the buccal or the inner side of the cheek, the oral swab, and never take a nasopharyngeal swab even in deceased. It can lead to a lot of there is no proven efficacy or the proven sensitivity is poor. It's not yet proved, and the risk of the person taking the sample in a deceased patient when we take a nasopharyngeal swab. So only oral swab is recommended for a deceased individual. Now, serology. What we need to identify is the previous exposure. This is done only for experimental purpose, previous exposure, and whether they are an asymptomatic or convalescent individual to understand how the disease is, if there is any mutation, how we respond to the infection, and whether the person has experienced any prior infection and has recovered, and for other epidemiological purposes. So serum is preferred, but plasma can also be used. So what about serology? Can it be used for diagnosis? Very, very rare. It is not recommended, but rarely can be used for diagnosis. So for diagnosis, it is only NAT, nucleic acid amplification test, in which real-time PCR, a subtype called real-time PCR is used, and it is done from the blood. That is the standard test for diagnosis in a living patient. Now, what is the general dogma? Antibody should not be used alone for diagnosis, but it can aid in diagnosis when your PCR test yields inconclusive results. So IgM detection in a recently acutely ill patient or IgG in paired samples which are collected at least 21 days apart. As I told you, the first sample has to be collected within the first week, and we look for raise in titers of IgG after 3 weeks. Now, recent vaccination, the vaccination is there for one particular strain, that is Xyrens, which has caused high mortality in Africa. So some people are vaccinated there. So that can interfere with the serology results of antibody. Now, sample storage. So within 24 hours, we can transport at an ambient temperature of 25 degrees C. For 1 to 7 days, it can be stored at 2 to 8. So if it is more than 7 days, it's better to freeze the sample at minus 20. So now this is similar, almost storing in the fridge and transporting the, another precaution which we have to take during sample transport will be the triple packing. So which is outside the scope for the GPs, but that is mandatory to pack. So I think before the sample is collected, enough training will be given from the government side before we start off the collection. So viral antigen, as I told you, these are the direct antigen detection tests. So I was talking about one outbreak in 2014 where 28,000 patients got affected. So during that time, the African government could not afford, or CDC could not do a PCR. So they went in for this rapid test. They evaluated this rapid test, at least for post-mortem diagnosis, or at least for where they could not afford a PCR, where they could not do the PCR. But the sensitivity is very poor, 60 to 80%. So the current epidemic, the WHO or CDC do not recommend these tests, but these tests are just available. So whole genome sequencing is for research purpose to understand the genetic mutations and how the disease has spread, to understand and to, so that we can plan the IPC protocols and plan how we have to go ahead in controlling the epidemic. Now, so diagnostic, again, once again, so diagnostic or follow-up testing in a living patient is only NAT, that is PCR. The sample type is EDTA blood or plasma. Oral or buccal swabbing should be avoided because the sensitivity is poor. In a deceased patient, oral or buccal swab is in a VTM, just like our COVID. So nasopharynx is not recommended in a deceased patient. Now, to identify the previous exposure and for epidemiological studies, or when there is a doubt in your PCR test, then it's better to go for serology. You can do serology. And next, during the acute phase of illness, all the other samples like CSF, the CSF or the breast milk, semen, everything can be taken up for analysis. So just to understand the disease, to understand where the virus persists and where the precautions have to be taken. So, and now, so in symptomatic, this is the test wise. So where it is recommended now, going to a symptomatic individual. So when your PCR or NAT is positive, it is an acute confirmed case. A rare scenario where NAT is negative and IgM is positive, we need to take into the consideration of the other clinical background of the patient, the epidemiological history, the geographical history before we term them as a confirmed case. So the second one has to be reported with a very, we have to take a lot of precautions before we report a NAT negative patient as a confirmed case. And the next one is, who is not a Ebola person? How can you exclude Ebola? That is, after 72 hours of symptom onset, we have one test which is PCR negative or NAT negative. The patient can be ruled of Ebola infection. He definitely doesn't have Ebola. Now, symptomatic. This is only for confirming the epidemiological purpose. As I told you, IgM and IgG is positive. Maybe he's a confirmed convalescent case, or IgM is negative and IgG is positive, but the sample is taken after 3 months. Then it is a confirmed convalescent case. And similar results, that is IgM negative and IgG positive in a patient who is less than 3 months of symptoms, then the results are considered to be equivalent. So mainly what we need to know is the symptomatic one. So NAT positive, it is confirmed case. NAT negative and IgM positive with a background of epidemiological confirmation and clinical correlation. then acute confirmed case, and even the other mimickers, they also should be ruled out when we call them as a confirmed case. And NAT negative is after 72 hours is not an Ebola. No. Is there a vaccine for Ebola? Yes, but none is specific to the particular strain which is causing the outbreak now. Now, existing vaccine is for the Xyren strain, and some protection cross protection can occur, but it is less effective. So only for experimental purpose it is tried, because it can give a false sense of security. And the vaccine which may come up to clinical trial in a couple of months or 3 months is the vaccine from the Oxford group. So that may come up soon in 2 to 3 months. So it is a promising candidate now, as of now. And we need to know the susceptibility to the disinfect, the viral susceptibility to the disinfect, having known about the test. So before we pack or before we send, what are the precautions we need to take? So the 1% hypochlorite, which has been working for HIV, which has been working for COVID, may not work for Ebola. So we need to increase the percentage of hypochlorite to 5%. So that is very important. And then what it feels like working in a Ebola research lab, just 5 minutes, I'll be completing my topic. So that is, wow, what is their experience? How a Ebola lab looks like? So these are a very few people in the entire world who work in the Ebola lab. So when the scientists, this is how the lab looks. When the scientists enter the lab, they hook into a bright yellow pod through which enables them, through which the oxygen is supplied. This is how a Ebola lab looks like. That is a BSL 4, biosafety level 4 lab. So it is like a deep sea, they put a dress like a deep sea divers, which has a pressure that will repel the contaminants. The only problem with the Ebola lab is the main concern is sharps. So during investigations, when they come across with sharp, it can prick their dress, so which can lead to contamination of or a breach in the PPE. And when scientists leave the lab, they will be showered with chemicals, just like a car wash, so that they are disinfected before they doff the PPE. And so this is from a scientist, so I didn't go into thinking I got to don my white coat, but arriving here, I think it's something that's really worth doing. So the story of the Ebola, the updates, 23 potential antiviral compounds are designed by the AI, now can act against Ebola. So the main, how the Ebola affects us is through it affects the antiviral defense genes of the body. And the donning and doffing, if we have time, I can go ahead, or I can.
Madam, sorry to interrupt you, madam. We have 2 more speakers and we have management of
I think I can stop it. So
yes,
that's all.
madam.
I am stopping it. I'll not share the video. Video is for 2 minutes. Can I share? Just 2 minutes?
Okay, madam. Yes, madam.
Because it tells how it is done.
With all the talk about how dangerous it is for healthcare workers to care for Ebola patients, we wanted to find out more about all the precautions they have to take. So we recently watched 2 nurses at the Mount Sinai Hospital in Manhattan learn how to put on and take off all the gear. In hospital speak, it's called donning and doffing. Welcome to the donning area. I'm going to be
and we need to have a separate person to monitor the donning for Ebola.
Make sure each piece is put on correctly and in the right order. First comes a full body coverall, but only halfway. Plastic thigh-high boots are pulled on over that. After zipping up, they don something called an N95 respirator. They'll check to make sure the seal is tight. Goggles are put on over the hood. And then there's a 4-length waterproof gown. There's a special knot for tying the back, and it's cut 2 inches long. Now, not 1, but 2 sets of rubber gloves, one inside the sleeve, and the other pulled on over the sleeve to seal it off. There's a second hood. Then to top it all off, a face shield. Nurses stretch out to check the fit.
Second hood and both goggle and face shields are used. Yeah, that's it. Now, is it a potential pandemic? The risk is theoretically less. Mutation possibility is very less, and only time should tell us. And so this is my last slide. So it is different from COVID in a lot of ways. The main important difference is the speed of transmission of COVID is huge, but here it spreads only through the close physical contact. The case fatality rate of COVID is only 1% to 13% in hospitalized patients. Here it is deadly, and PPE is less stringent, whereas for Ebola it is more stringent. Asymptomatic individuals spread the disease in COVID, but Ebola they do not spread. And the symptoms and risk to the general public and travelers was more in COVID, but here the risk is less unless you are in close contact with a symptomatic patient. Pandemic potential is more for COVID, as we all know. And take home message. So NAT is the test. The symptoms we need to be we need to be aware of the symptoms, the hemorrhagic symptoms. 21 days quarantine is a must for suspected cases, and the initial recommendation of CDC is now revised to the upgraded recommendation for Ebola. The initial PPE, routine PPE doesn't apply for Ebola. So that's it. Thank you. Thanks. I'm sorry for taking more time.
Thank you, madam.
Thanks, Swati. That was wonderful presentations. We'll take the questions at the end because we are running short of time there.
Yes.
Yes,
We'll go to the next speaker, Dr. Namita.
Yes, sir.
Sendil, can you introduce her?
Yes, sir. Sir, Ibrahim, sir, he's planning to introduce.
Yes, sir. Thank you, sir. Welcome, Dr. Namita, madam. So, Dr. Namita Narayanan is the professor, Institute of Internal Medicine, Madras Medical College, Chennai. And she is a member of the Expert Committee on Quality Improvement in Medical Education, DMER, Government of Tamil Nadu. And also an executive member of API Chennai chapter. She is a member, Scientific Committee, Kalaignar Centenary International Medical Conference in 2024 and GCDC 2022 and 23. She has been invited as speaker at various national and international conferences and published several articles in prestigious medical journals and written chapters in APCON Update, and conducted various intra and intra-college quiz competition and state-level inter-college PG quiz competition in TAPICON 2017 and APA Chennai chapter 2022, 23 and 24. Her field of interest is critical care medicine, toxicology and medical education. Over to Dr. Namita, please.
Thank you, sir. Good evening, all. Hope I'm audible.
Yes,
Yes, madam.
Yes, sir. My slides are visible, sir.
Yes, madam.
Yes, madam. Visible.
Yes, sir. Yes, sir. Thank you very much, sir. At the outset, I'd like to thank the organizers for this opportunity, especially Nirmal Frederick, sir, and Dr. Sendil, sir, for having given me this opportunity. I think the previous speaker has made my job very easy. It will be a repetition of whatever. So it will be a reiteration of whatever we know about Ebola. So moving on, as we all know, it has been declared as a public emergency on May 17th by public health emergency of international concern by the WHO. So it is now happening in the Democratic Republic of Congo, Uganda, and South Sudan. And the disease spreads, as we know, through direct contact with the person or because of the fluids. So as on 21st May 2026, we had 575 suspected cases, of which 51 were confirmed, and there were 148 deaths, which was reported. And case fatality is approximately 50%. It can vary from 25 to 90%. So it is a rare, severe, and non-fatal viral hemorrhagic disease affecting humans and non-human primates. All this has been already said. It is an enveloped RNA virus first identified in 1976 near Ebola River in the Democratic Republic of Congo. There are 6 identified species, but these 3, Ebola, Sudan, and Bundibugyo, are the ones which have caused human outbreaks, and the present outbreak is by the Bundibugyo virus. So it belongs to the family Filoviridae, and the genome, it is a negative sense ssRNA, and it is filamentous in shape. This is how it looks like. And we've gone through all this, but again, the reservoir and host, the natural reservoir being fruit bats, are considered as the main reservoir, and the intermediate host being non-human primates, gorillas, chimpanzees, and porcupines. And human infections are accidental hosts. Infections occur through the zoonotic spillover. So fruit bats, natural reservoir, not only for Ebola, we also know that we have had an epidemic of Nipah in Kerala. So that is the same reservoir for this also. It circulates among bats in forests, and they maintain the virus in nature without developing severe disease. And a spillover can occur when the Ebola virus spreads from bats to wild animals. And Accidental host would be human beings, where they get infected through direct contact with infected bats or wild animals, hunting and handling bush meat, or exposure to blood, organs, or body fluids of infected animals. So this is a cycle which we went through. So human to human transmission direct would be through blood, saliva, vomitus, semen, sweat, or urine, even through breast milk. And indirect transmission would be through contaminated needles, bedding, medical equipment, and fomites. And especially for us healthcare workers, any poor infection control practices, lack of PPE, and unsafe burial practice of the most cases reported in Africa were because why? Because it was because of the burial that many people attended, and that is how many got infected. So moving on to the clinical features. So incubation period is 2 to 21 days, and this starts once the patient becomes symptomatic. Only then he is able to spread it to the other patients. So it has got two phases. One is a dry phase, another is a wet phase. Dry phase, it begins with sudden flu-like symptoms, and then it progresses to gastrointestinal symptoms. So this early phase, it is typically non-specific. It can mimic any flu-like illness, and all are tropical illness like dengue, malaria, and whatnot. And you have high-grade fever, severe fatigue, malaise, myalgia, severe headache, and then sore throat and dry cough are also common. So all these are typical viral picture, which then moves on to wet symptoms like severe watery diarrhea, nausea, vomiting, and abdominal pain. So due to diarrhea and fluid loss, patient gets into dehydration, hypovolemic shock, and the fluid loss can be up to 10 to 15 liters. That's what they say in severe cases. And typically, like dengue, also they can have a non-itchy maculopapular rash, often appears on the trunk and arms during this phase. So this is usually happens from day 4 to 10. And the late and severe phase is where patients may experience unexplained hemorrhaging. They can have petechial and mucosal bleeding, or blood and stool or vomit. They can have marked electrolyte imbalance, and they can go in for MODS, especially kidney AKI can happen, liver functions can become deranged. Neurological complications can occur like confusion and seizures, and multi-organ failure can also happen. So what are the operational definitions according to the Ministry of Health and Family Welfare? We have a suspect case where the patient presents with fever and acute clinical symptoms and signs of hemorrhage, bleeding of gums, red spots on body, and blood and stools, plus history of travel to affected area in the last 21 days. So this is the 21 days is a magic number, and the history of travel is very important before we label any case as Ebola. Probable case is a suspect case, again, with the history of contact with a confirmed Ebola case in the last 21 days. And with the laboratory confirmation, we get a confirmed case. So contact is one who has no symptoms, but he's shared the same room, bed, or cared for a patient, touched body fluids, or closely participated in a burial with physical contact with the corpse, again, in the last 21 days. So this is the operational definition for contact. So what are we going to do here once they come into the airports or through sea? There is a strict monitoring process which is happening now in airports and the ports. So passengers coming from the affected countries without any symptoms, without any contact history, but they have come from those countries of Africa, they are advised to do self-monitoring at home. So home isolation for 21 days, and they are monitored by the district health officers and the surveillance officers. In case they develop symptoms, they are then brought into the quarantine centers. So category 2 are passengers from affected countries, again, without any symptoms, but they have a positive contact history. These patients are to be, or these passengers are to be quarantined for 21 days, and they are again under the surveillance. So category 3 is where when they develop symptoms, even if it is fever for 1 day, and then they're transported to the isolation facility, and collection of storage and transport of sample is done, contact list and tracing is done, and contact follow-up is also done. So the same here, epidemiological case definitions is a suspect case, what we have already discussed, a probable case with or without bleeding, a suspected or probable case with laboratory confirmation, positive antibody or positive PCR or viral by any ICMR designated laboratory. And confirmed case is any suspect case having had contact with a confirmed case of Ebola disease in the last 21 days with the lab positivity, and contact is what we've already spoken about. So clinical management, as I said, it mimics any tropical illness. So, and it doesn't have, as of now, this strain doesn't have any specific management protocols. It is only supportive management, and we don't have any vaccines. So this is the PPE. We also saw the donning and doffing. So how does this PPE differ from the PPE that we had during COVID is that this is fluid resistant and it should be fluid impermeable. Not only should the healthcare workers wear the PPEs, but it was advised by the DGHS ICMR in a meeting 2 days back that the patient's dress and linen, everything should be put in a bag, and it should be put in a biohazard bag and left it separate inside the isolation ward. And the patient should also be given fluid resistant overalls and a shoe cover so that he also doesn't spread it to the healthcare workers also. So nothing which goes into the isolation ward should come out of the isolation ward. All should be decontaminated. So this is a PPE. You have an overall, you have an apron over it. You have a face sheet and goggles, and you also have shoe covers and double pair of gloves and an additional gown. So hand hygiene, again, I'll stress upon this because more than the doctors and the patients, that is the people who are handling all these ways, the healthcare workers especially, and hand hygiene is very important here. Use strong 0.5% chlorine solution and gloved hands. And after every contact with the patient, we are supposed to have an alcohol hand rub and wash our hands. And washing hands with soap and water, all with alcohol hand rub. And these are the 5 essential moments hand hygiene needs to be performed before donning, after each step of doffing, after complete doffing again. More than donning, doffing is very infectious. And as Madam pointed out, you should have a buddy with a checklist, and the buddy who sees whether you're wearing it properly should also have donned the PPE. So after each step of doffing and after complete doffing, visual or probable contamination of gloves, after examining the patient and after medical interventions, after handling biomedical waste, discard or spill or decontamination procedures, and after handling human remains. So all these are moments where hand hygiene is very, very essential. So what do we normally do? We adequate hand washing with water and soap requires 40 to 60 seconds, and alcohol-based rubbing needs 20 to 30 seconds. But we all of us have a habit of doing it for less than 10 seconds. That should not be done. We should have, and we should follow the strict protocols. So how does the isolation and access should be? The healthcare workers should have a full PPE. Even the ambulance driver who shifts the patient should have a full PPE. And rooms and isolation facilities should be single rooms with an exclusive restroom for each patient. It should not be a common ward with a common toilet. So that is very mandatory when we set up an isolation facility, because it is, again, it can, people can get contaminated using the same toilet. So it is advised that they should have a separate room with a separate restroom identified for every patient. So single negative pressure room, HEPA filter, exhaust if available. Otherwise, a single room with door closed and a dedicated toilet. So what do we do? The initial assessment, this is done in the entry points, whether detailed history, travel, and whether they had any contact with any positive case of Ebola or a symptomatic case of Ebola. And if it is a healthcare worker, again, ask whether they had a contact with any patient with confirmed case of Ebola. Vitals need to be monitored every 1 to 2 hours. Continuous SpO2 monitoring and cardiac monitoring, and a strict input and output charting is necessary. Daily urine output and hourly urine output should be measured. Daily weight, and also the quantified stool and vomitous volumes. As I already alluded to, we don't have a drugs for this. So it is only supportive management. So as in any shock or a septic shock, we are going to give an isolated bolus fluid resuscitation, isotonic crystalloid, RL 20 to 30 ml per kg bolus for shock, and then titrated to an output of more than 0.5 ml per kg per hour, and maintain a mean arterial pressure of more than 65, and look for the lactate also. And electrolyte replacement where and when necessary, especially potassium, sodium, magnesium, and calcium. And also watch out for arrhythmias. Antiemetics if necessary, and antidiarrheals, loperamide, only after ruling out any invasive bacterial cause, and oral rehydration if the patient is tolerating. So antipyretics can be used. Avoid NSAIDs and aspirin, as we know it is a hemorrhagic fever. As in dengue, we will avoid all NSAIDs and aspirins here. Pain control, again, go in for paracetamol. Nutritional support is necessary. If the patient is not tolerating oral, again, NG tube feedings can be done. Parenteral, if there is any paralytic ileus. And empirical antibiotics, again, when there is a secondary sepsis and not for Ebola per se. So again, if the patient is in shock, the first line of inotrope of choice would be noradrenaline, followed by vasopressin if the shock is refractory, renal support early if required, and respiratory support as and when required. And if the patient is in coagulopathy, vitamin K and FFP for active bleeding. And if the platelets is less than 20,000, again, we can support them with products, fresh frozen plasma. And a patient with bleeding less than 50 also can be given the products. So again and again, we are alluding to this. There is no licensed monoclonal antibody as of now, and there is no licensed vaccine for this current Bundibugyo strain of Ebola virus. So, and it is also necessary to avoid aerosol generating procedures unless and until it is very essential. And when we are doing so, it should be done with full precautions as we did in COVID. COVID was more of aerosol generating. So, but here, the patient transmits infection only when he is symptomatic and only when we come in direct contact with the fomite. So avoid nebulization, use inhaler devices if required, and use closed suction circuits if intubated. So when do you refer a patient from, say, from an isolation facility or a quarantine facility to a higher center? When there is clinical deterioration, bleeding, respiratory distress, oxygen saturation less than 94%, hemodynamic instability, altered sensorium, seizures and confusion, and renal dysfunction. So these are the parameters when they have to be referred to a higher center when the patient is sick. And when we refer, we need to priorly intimate the isolation facility. Now, in Chennai, RGGH is ready with an isolation facility for patients flying through air, and Stanley is ready with the isolation facility for patients who come through the sea. So we are all prepared in the eventuality of in case we get a case. So they should inform from the airport or port that they would be sending such and such patient with all the clinical details, with history, and also they do categorize the patient and send it to us. So treatment, as I said, these two monoclonal antibodies which are approved for FDA is for the ZAS strain and not for the Bundibugyo strain. This is Inmazeb and Ibanga, which has been used for the previous strains. And as of now, WHO on 28th May said that they are recommending 3 treatments, but it's still under evaluation. The monoclonal antibodies called as MBBP 134, another is Maftivimab, and very famous antiviral Remdesivir. All these are under evaluation, but protocols have not been issued yet. And vaccines, again, these for the ZAR strains. One is Ervebo, which is single dose live attenuated vaccine, highly effective against the ZAR strain of Ebola virus. It was used widely during the outbreak control programs, and these are the other 2 vaccines. But for now, Oxford Group, I think she also had told this, Oxford Group's vaccine is undergoing animal trials, and this can be ready in 2 or 3 months. We are not sure yet. So this is about the cleaning, this is about the treatment for the individual. So I would stress more on the environmental cleaning and decontamination procedure than all these what we've said. And when we see a patient, we need to maintain at least a 1 meter distance when we see a patient. And even during the triad center, the donning area should be different, the doffing and the exit should be different, and we should have separate entry and exit for the doctors and the patient. So why this is important? Because it reduces risk by disrupting the chain of transmission. Disinfect the commonly touched surfaces, because even on plastic surfaces, it is seen to survive for 5 to 10 days. So, and it is very much amenable to our sodium hypochlorite solution. So it is very easy to disinfect. So disinfect commonly touched surfaces in areas, which is regularly done on a scheduled basis. Cleaning and disinfection are high-risk activities for the cleaning personnel. So they should be taught about the proper donning and doffing, and about the double glove wearing, and to throw away the glove and the glove which they are wearing. So clean with soap and water, remove debris before applying disinfectant, and disinfect strong 0.5% chlorine solution wipes. And it is advised to use a wet mop than a dry mop. So what are the areas to be decontaminated? The donning area, the doorknobs, biohazard bin, the SS tool, the room floor, everything. And we go from clean to dirty areas when we mop. And isolation rooms and all the BP apparatus. So whatever goes into the isolation facility, the ventilator, BP apparatus, your strength, nothing should come out of the isolation facility. So collection and transport protocol, again, the linen, again, it should be folded inside out so that you don't touch it. That the same thing when we doff also, we have to do it from inside out so that we don't touch the outer surface, and never shake or agitate the linen, as this can generate infectious aerosols. Pack the linen immediately, place in the rolled linen directly into a sturdy, clearly labeled proof biohazard bag. Do not manually compress or push down on the linen to fit more into the bag. You like how we transport the samples that we take from the lab. This is also has to be labeled biohazard, and maybe a triple packing also has to be done. And what would be the incineration rule? If linen is grossly contaminated, then it should not be laundered. It should be incinerated. It must be treated as category A infectious biomedical waste. And laundering in high temperature and chemical disinfection. And we need to have separate color-coded bins and availability of space to dry up the autoclaved and decontaminated usable PPE. So it is more of decontamination, which is important. So, and again, with the patients coming by ambulance, so the ambulance also should be decontaminated, the stretcher, everything. And the ambulance driver and the co-pilot should also have a PPE worn. So I'm not going into the biomedical waste management. So with this, so take home would be the incubation period is 2 to 21 days. Once the patient gets infected, we categorize them into 3. If he's asymptomatic, we give him a home isolation. And if he's in contact, asymptomatic with contact, again, have him in a quarantine facility. Symptomatic and with history of contact from the countries which we already mentioned, then shifting to an isolation facility. So decontamination procedures, be very careful about the infection prevention protocol. With this, I finish. And I once again thank all the organizers for this wonderful opportunity. Thank you, sir.
Thank you, Dr. Namita, for a wonderful talk there. So a couple of questions already posted, so we can keep the discussions at the end there so that we can have sufficient time. Another 15-20 minutes. We'll finish the third talk also. Then we'll start the Q&A session.
Yes, sir.
One second. I hope the slides are visible there.
Yes, sir.
Yeah.
It's visible.
So yeah, already a lot of talk about the Ebola is going around. We come back to the Ebola little practical point, little later point of it there. Whatever theory they both microbiological aspects as well as infection control aspects and clinical aspects they touched upon it. But I'll show a couple of practical FAQs what the clinician need to know at the end of my zombie test there. So people are worried about it. When I told this topic zombie test to the secretary was asking what is zombie test. Zombie tests are nothing but if I'll come back before the disclosures, ID doctors won't make money. We try to solve the problem so we can happy with the way we solve the problem and solve the problem created by other doctors here. So this is very happy for us there. Right? So I'll begin with the straight away with a couple of cases before coming back to what is zombie there. So this is a interesting patients we have seen, 24-year-old person. He himself is a doctor doing her post graduations in Chennai, native of Coimbatore. He got fever of 4 days durations. Initially, little bit of constipation was going around. Now diarrhea, she came to us. On examinations, febrile spleen was palpable. Investigation showed WBC count of 3,800, essentially normal differential count with a CRP of 45 slightly elevated, not slightly, moderately elevated. Urine routine showed couple of cells. Urine culture is going equally 10 to the power of 5. Vidal test was done, 1 in 320 is positive. Lepto IgM is positive, Manto is 10 millimeter reactions. I think people are putting the name and asking for the certifications, TNMSC credits. I hope the team need to answer to get the credit points so that we can discuss at the end. What is your diagnosis here? 24-year-old young female doctor from doing PG in Chennai, native of Coimbatore. Right now, fear of 4 days durations, initial some constipations, essentially some spleen is slightly palpable. What do you think about it? What's your diagnosis here? How many playing God? I do not know. So what's your diagnosis? Just go ahead and put it in the chat so that we can discuss. I'm seeing only 6 or 7. I don't think so. That is a TNMC credit point message, or whether it's a really participating message, because so many people are, good people are saying 6 and 1. That's a good thing there. So really people are participating. That's a good thing. Even at the end of 2, talks on Ebola, people say none of the above. So this is what they're telling it. Okay, good. So no typhoid, no leptospirosis, no UTI, no TB, all of the above, none of the above. Always when we keep the choices, all of the above, none of the above, people always a little tempt to one about the thing. Okay, the same case. Now the fever panel, this comes under fever panel, Vidal test, leptospirosis. Before you open these questions, how many say, people say, I do fever panel in my hospitals. Is there a specific fever panel? Because if you see the most of the laboratories outside, they run a fever panel. If some outbreaks happen, they created a panel for that also there. Is there any fever panel in your hospitals you are running or not? First questions I need to answer. Yes, in my hospital, I got a specific fever panel. Second thing, if you got a fever panel, what are all the things included? I just put a couple of things there. Vidal, lepto IgM, urine for culture and sensitivity, Manto test, CRP, or extra fever panel. So whatever things you just go and put in the chat so that we can discuss at the end of our presentations. So is there any fever panel? People say still voting for IMA credits only, they're putting the numbers. I just want to see cultures. So they include cultures also in the fever panel. They say Manto is there in the fever panel. Great. A lot of people are actively participating. Please everyone keep your just to listen there. Please keep. Previously keep muted. So previously please all people muted so that other people can listen there. Yeah. Dengue IgM is missing out there. People say cultures, okay. So they're saying about the diagnosis, about the fever panel, people are not answering. Any fever panel in your hospital that includes more data there. So I'll come back to the thing now. What is zombie? I need to reveal the answer for zombie. So this is my idea today there. Why this topic? What are the common zombie tests we do? Approach to fever without zombie test and summary and way forward. I don't want any big tests or zombie tests. I want to simply shoot the acute fever management in a daily practice here. So what is a zombie test? Essentially, the zombie means that they are dead, but we are giving life to the people who are dead. That means the testers are all dead, but still we are keep using the test. There is no meaning for this test. These are all dead tests, already used, outdated. Nobody want to use this test. That's called the zombie. But since the clinicians are using it, they are giving life to the test. There is no meaning for this test if you start using the test. So in short, dead test, but we are given life to the test. It has got no meaning. It has got lack sensitivity, specificity. You can't make a diagnosis. Only thing the zombie test can delay the diagnosis. Appropriate diagnosis can be delayed with the zombie test. So keep in mind that tests are dead. We need to remove the dead test. For example, what happened in the recent election, they're doing a SIR process there. They want to remove a lot of electorates that not participate active roles. They removed it. Similarly, these tests should be removed from your practice in the future. That is the basic idea of this doing this talk there. So inappropriate and wrong usage of diagnostic tests. Some tests, if you are not using properly, that is also become zombie for you. Lot of abuse is happening there. I'll come back and explain a lot of abuse is happening. What are all the zombie to you there? So the first zombie test is a typhoid, particularly the Vidal test. People use it. So this is taken from WHO manual. Vidal is a test of historical interest. That means the test is a dead. It's not live. This is a test of historical interest. We can't make a diagnosis of typhoid by doing one single viral test. People say 1 in 360 came back positive. People always says to the always to the patients 1 in 40 positive diagnosis is typhoid. This make the diagnosis of real diseases late. For example, the patient I saw a couple of days back, the person is a young guy, but the person going for fever of 2 weeks durations, and the person has got fever, cough is going on. Somebody did the Vidal test came back 1 in 80, the O dilutions 1 in 80. They told the patients you got typhoid. They started giving ceftriaxone, the person giving azithromycin. They tried all sorts of antibiotic, but fever was keep persisting. But other simple diagnostic clues showing to us this is not typhoid to me. But unfortunately, the clinicians, because of the zombie test he did, the zombie test confused the picture. The real diagnosis has not happened to him. Why Vidal is a zombie test? The Vidal can cause false positivity. I'm talking about single Vidal. If you see the single Vidal, it gives a lot of false positivity. For example, E. coli in the blood can cause false positive Vidal. Similarly, if you got dengue can cause false positive Vidal. If you do the test, for example, on day 1, day 2, Vidal may remain negative. The person taken antibiotics, if you do his Vidal test, is again become negative. So we need to remember there are so many Salmonella species are there. Only 4: Salmonella typhi, paratyphi A, paratyphi B, rarely paratyphi C, and rarely Salmonella typhimurium. Apart from these species, most of the Salmonella are environmental commensals. Exposure to the environmental Salmonella can cause false positive Vidal. So don't say. Similarly, once the person has got real typhoid, blood culture proven typhoid, how long the test remain positive, we do not know. What is a significant titer? 1 in 40, 1 in 80, 1 in 160, 1 in 320. No studies has been conducted. So this is a test of historical interest. If you do the test, you are not going to make the diagnosis there. It's very easy to say this is a zombie test. Then you can ask, blood culture will take 5 days. But nowadays we are using automatic system. My microbiologist colleague knows very well. Once we send the blood cultures, next day I call the microbiology lab. What is the growth? Can you tell, please? So this is what we do. But for a ordinary practitioner sitting there, I don't have access to the blood culture. That is why I'm doing Vidal. That's why I'm giving life to the zombie test. This is a simple thing. If you do in a good lab on day 1, day 2 itself, but most important thing, history. When a person should get typhoid, when the person is going to get typhoid, you need to eat outside food. Typhoid is a foodborne disease, not like Ebola. Ebola is a close contact, but typhoid is a foodborne. So the person should eat outside food. The person should eat outside food if the food is not cooked, not boiled, not peeled, like vegetable salads, fruit salads, ice creams, juices, pani puri, chutney, curd rice. Eating most of the time, staying in a hostel. This person is a classic example, staying in a hostel, eating all sorts of food in the hostel nearby. So the person chances of developing typhoid is very high. Second thing, we need to look at the WBC count. The WBC count is normal and eosinophil count is 0. But this is only happening in a good lab. So many strata motor labs we are seeing the eosinophil count is 4. When they do the test in my hospital, the eosinophil count is 0. I'm talking about the percentage. The percentage is 0. Young individual eating outside food and the ESR is normal. The chances of typhoid is almost 90%. That's the data we produced a couple of decades back. In fact, 2013. This is a small publication from the Kanchi Kamakodi. They are saying this is 76% sensitive. But in my hospital, this is 92% sensitive. This is a paper we produced a decade back. So this is the data. I'm talking about with the data only. I'm talking about it. This is our own experiences. So Vidal is the first zombie test. In your future, don't do this dead test. If you do the dead test, you are delaying the diagnosis. You are causing harm to the patients. You are given a life to the test that is useless to you there. And second thing, people want to do serological tests. For example, leptospirosis and strep typhus. The person is just 4-day-old fever. If you go back to the case history, this patient has got 4 days fever. 4 days fever, where the person has got serology is going to be positive. We need to wait for minimum 5 to 7 days. Minimum is 5. Ideal is 7 days for IgM to form. But people are doing on day 3, day 4 and saying that I did MAT test, I did MSAT test, it is negative. Usually leptospirosis and strep typhus, not only for usual leptospirosis and strep typhus, all serological tests we need to take with a pinch of salt. We need to know what is my pre-test possibility, what time I did the test. For example, if I do the test after 7 to 10 days, my pre-test possibility, for example, leptospirosis, the person should walk through the rainwater, the person should wade through the rainwater, then only we need to give importance. Otherwise, clinical diagnosis, we can make a leptospirosis and strep typhus. How to make a clinical diagnosis? Wait till end of my presentations, I solve the problem to you. That's what we need to do. And third thing, leptodiagnosis means this is one of the simple criteria called modified Fain's criteria. We need to know the epidemiological history. We need to know epidemiological. Typhoid comes through the food. Leptospirosis comes through the walking water, wading water, standing in agricultural field. or taking swimming in unknown place where we do not know the quality of water, or hiking or something there where we went for small falls or river water exposure we can there. So these things we can keep in mind. Unless this history is not there, don't give importance to leptospirosis. So what is the leptospirosis approach? Take proper history, do proper examinations, water and bushy area exposures, standing in agricultural field, recent floodwater exposure. Yes, we can put our money on leptospirosis, not the lepto IgM test on day 3, day 4. If you want to do the test, yes, we can do after 7th day or 10th day, but always take with a pinch of salt, because all serological tests, particularly IgM serology, always we need to take with a pinch of salt. So don't interpret the test there. So that's the easiest way. How to interpret leptospirosis? The person should walk through the rainwater, wade through the rainwater, agricultural field stand exposures, and in step typhus, again, bushy area can be there. WBC count is elevated, low platelet. If you see the LFT, alkaline phosphatase, more elevated, gamma GDP is more elevated. That's called cholestatic pattern. Cholestatic pattern, typical exposure history, elevated WBC, low platelet. I put my money on leptospirosis. If the step typhus, strip the patients, examine the patients, because they won't tell I got Ishka. We need to examine the patient. That's most important for you. So the third test is people always want to do MAN2 to take a diagnosis of tuberculosis. Almost all patients MAN2 they do. So serological test is one of the zombie tests. If you do before day 5 without knowing the pre-test possibility, that's a zombie test. The third zombie test in your practice is called MAN2 or TB quantiferon gold. Both are same. TB quantiferon is a glorified MAN2. The both MAN2 and TB quantiferon gold. The TB quantiferon gold is diagnosing latent TB. That means the TB bacilli present in your body or not. It won't say the TB bacilli present in the body is causing disease or not. Absolutely no. So don't do MAN2 test and say MAN2 test is positive, I want to start 4-drug ATT. No. MAN2 is only for latent TB. If you do MAN2 or TB quantiferon for diagnosing active TB, this is a zombie. This is a zombie. This test was introduced only for finding out latent TB, not for the active TB. Keep in mind. That's why I said certain tests for latent TB, this is a good test. For active TB, this is not a good test at all. This is a zombie test there. You are giving life. Based upon the MAN2 test positivity, based upon the quantiferon TB gold, don't say the person has got tuberculosis. This is absolute only for latent TB. If you see clearly it showed zombie test. Why? Because we can't make a diagnosis. 25 millimeter MAN2, no, that is only latent TB. It won't say active TB. Similarly, for quantiferon TB gold, only advantage, it has got not going to positive for BCG. MAN2 will positive for BCG, particularly for children. I saw a child 2 years old. They did a MAN2 test. Because of the BCG showed positivity, we do not know. People want to put TB medicine, they refer to me. Fortunately, we intervene and stop. So zombie test can cause not only delay the diagnosis, give harm to the patients, giving a lot of false medications and extra medication that kill the patients also there. The third thing is about urine cultures. Urine cultures is a gold standard. That is not zombie to me. But when urine culture is a zombie to me, most of the residents, they call me there. Sir, the patient's urine culture is 10 to the power of 5 E. coli. What antibiotic to start? When I ask what is the symptoms of UTI, they won't say, sir, no, sir, only urine culture report is there. If you ask any symptoms, they won't say. If you ask any urine routine you did, they won't say. So urine cultures, if you do without asking the symptoms, without doing a urine routine, this is a zombie test to be there. So we need to ask urine symptoms first. This is called one of the simple score called bladder score. What is bladder? B stands for blood in the urine. L stands for loss of urinary continence, incontinence. A stands for abdominal pain, lower abdominal pain. D stands for dysuria. There are 2 D's in the bladder. So D carries 2 points. E stands for elevated temperature or fever. And R stands for recurrent urinations or polyuria. So this is a simple bladder score. Write the bladder score. If the score is 4 and above, yes, you need to do urine routine along with urine cultures. But when the score is 0, 1, 2, don't do urine cultures. But people always send urine cultures whenever the patient has got fever. Whether the person has got symptoms or not, they want to do urine cultures. So when the person without having urinary symptoms, if you do urine culture, that is called zombie. If the person has got symptoms, urine routine showing pus cells, then you do the cultures, that's fine. But without symptoms, without urine routine, if you do urine cultures alone, that is called zombie test to me there. That's what I'm making here. So urine routine, why? Presence of pus cells may be UTI, may not be UTI. Absence of pus cells, there is no urine routine. Don't read bacteria is present in the urine routine. You need to see the pus cells. And the pus cells is more than 10, may be UTI. I'm not saying presence of pus cells is indicating UTI, may be UTI. Because when the person taking less amount of urine, concentrated urine, Lot of other conditions. For example, SLE patients or some other patients with the vasculitis, they can have WBC count high. But don't say straight away WBC high UTI. Maybe UTI. But why I do urine routine? When pus cells were not there, for example, 0 to 5, then it rules out UTI. That's why ask symptom, do urine routine, then decide about urine cultures. Straight away, if you do urine cultures, you are doing a zombie test. So that why the zombie test, where I got this name. So this is a beautiful paper. This only said zombie tests are back. They're talking about CRP. I put CRP in my first case. CRP is a useless test, cannot make a diagnosis. ESR and CRP only assess in monitoring response to your treatment. For example, the person has got osteomyelitis, septic arthritis. Other person is clinically improving, that is fine. If you want to assess laboratory wise, it may help. But for making a diagnosis of any infection, CRP and ESR is a zombie to me there. Never do ESR and CRP. Then comes to the ICU. ICU people, they want to start procalcitonin. Procalcitonin is very high, I want to start antibiotic. Procalcitonin can go up in burns patients, pancreatitis, trauma, major surgery, all can go procalcitonin. One of the center, I work in a cardiothoracic center, they do CABG. Next day, they do procalcitonin for one fever. After CABG, some amount of fever can happen next day. Major surgery, they do procalcitonin immediately on day 2. Procalcitonin skyrocket. They call procal. I want to start from whatever antibiotic they started as a prophylaxis, cefuroxime, they immediately change over to meropenem. So procalcitonin will not make a diagnosis of sepsis. Where we can use procalcitonin to stop antibiotics. When the antibiotic course is over, I want to stop antibiotic. When the procalcitonin is normal, we can stop. But procalcitonin cannot make diagnosis of sepsis. If you use procalcitonin to make diagnosis of sepsis, this is a zombie. If you are using CRP to make a diagnosis of active bacterial infections, you are zombie. During COVID time, most of the CRP gone up. Keep in mind. So these are the things. This is my last case here. People come back. This is one of the patients post and underwent craniotomy, tracheostomy, staying in a hospital for quite some time. One episode of fever in ICU. The ICU doctors not only do procalcitonin to make a diagnosis, they send one episode of fever, they send blood cultures, ET cultures, urine cultures, and wound swab. Everything they send because they want to make a diagnosis of. What is the reason for the fever. So what is the rank? I want to see the responses from the audience because almost 530 audience are sitting right now. So I want to check how many say this is a correct approach. Send all the things because we need to find out. Still people are going for credit points, not actively participating. Just go ahead and answer. What is the right approach here? Or what test we should not do in this patient? Can you say what test is a wrong test? I'll wait for a minute here. So I want to check people are participating or not. So how many are there? So what test is not a good test? People develop fever, they immediately want to do every test. 7. Urine cultures. Now they have got the point. Urine cultures without urinary symptoms is a useless test. That's a good point conveyed there. None of the above is a good answer. In webinars, people say none of the above, but in real life, when a person comes to your ICU, one episode of fever, they want to do all tests to find out. If you want to find out, the second thing is what do you call zombie? For example, I did in my undergraduations, post-graduation as an assistant professor also in one of the leading medical colleges in Chennai. So what happened in government medical colleges here? So the problem is, when I was doing my undergraduations, post-graduations, I never find a blood culture proven typhoid. Why? The medical college is not good. The medical college no government said is not good. No. The problem is I sent 2 ml of blood, 3 ml of blood to expect blood cultures to grow salmonella typhi. But now as a practicing, I send 20 ml of blood or 40 ml of blood. If I send 20 ml to 40 ml, the pickup rate is almost 70 to 80%. If I send 2 ml or 3 ml of the blood, that is called zombie test. So if you order a blood cultures, you need to order 1 set minimum in OP patients. In IP patients, 2 sets. 1 set means 1 bottle of aerobic, 1 bottle of anaerobic. Aerobic 10 ml, anaerobic 10 ml we need to do. Similarly, for 2 sets means we need to send 4 bottles. The 4 bottles, the pickup rate is almost 75% to 80%. So this is why we need to do. That is why I'm getting culture positive, blood culture positive typhoid now. Why I'm not getting the typhoid in my undergraduations, post-graduations, 2 ml, 3 ml blood. Volume plays more important. If we make a diagnosis of tuberculosis meningitis, send 6 ml of CSF. If the 6 ml is not gone, that is a zombie. If you send 1 ml, 2 ml blood to the blood cultures, you are zombie. If you send only 1 bottle for blood cultures, it's a zombie test to me there. So similarly, the panel. People always want to do fever panel. I want to do pan cultures. ICU means pan cultures. If you do a pan cultures without thinking what you need to make a diagnosis, it's a zombie test to me there. The fever panel is a zombie test. You're not making any diagnosis. If you are doing a all test pan cultures in ICU, because this patient, if you see, the person is a stable patient. One episode of fever, this is because of the thrombophlebitis related fever. I examined the patient, I said, advised to stop antibiotic. Unfortunately, they did the panel of tests of pan cultures. After seeing the pan cultures, people keep on adding antibiotics, so much of antibiotic, and the person is a stable patient. So the dictum, if the person has got one episode of fever, stable patients, examine what is your diagnosis. According to the diagnosis, whether test is required. If needed, yes, send the test, but appropriate volume, appropriate time, that's more important. Without knowing appropriate volume, appropriate time, don't do the test. If you do the test, it's become a zombie. So certain tests are real tests, but if you do at a wrong time, in a wrong method, that is zombie there. So zombie means not only the test that is outdated like Vidal, the test like Manto used for latent TB or using for active TB. Similarly, CRP for monitoring and procalcitonin for stopping antibiotic. If you're using for diagnosis, that's a zombie test. And similarly, when the patient has got fever, without evaluating the patients, asking the pan culture, that is a zombie to me there. So keep in mind, why the zombie test? I told one, it makes a delay in diagnosis. Two, unnecessary medications to the patient. Three, the most important pandemic, drug resistance we are facing. That's the most important thing. That's the problem we are facing right now. So this is why we need to avoid zombie tests. In 2003, meropenem is working in India 99% of the time. In 2013, only 50%. Why? Urine cultures, people start E. coli with all sorts of antibiotic. Previously, one dose of norfloxacin working for the UTI. Now meropenem is not working because we treat urine cultures, not the patient. That's the reason. This is a culture plate. In 2003, almost all the drugs are sensitive. In 2009, hardly one drug. If you see the reaction pattern, hardly one drug is sensitive. And the resistance pattern is too much. This is because we are using zombie tests. This is why we are saying avoid zombie tests in your practice. These are all the zombie tests. Vidal test is a zombie test. Other tests like MAN2 for making diagnosis of tuberculosis disease. CRP to make a diagnosis of sepsis, bacterial sepsis. Similarly, procalcitonin to start diagnosis of sepsis and antibiotics. And fever panels in OP. Pan cultures in ICU. These are all zombie tests to me there. So don't do this test. ASO to make a rheumatic fever. All the zombies don't do this test. Serological test within day 3, day 4. When you got another clue. It is very easy to criticize. So what approach? When the person comes to you, take proper history. Try to localize the disease. Do some basic tests like CBC and LFT. With CBC and LFT and write the diagnosis. Diagnosis is most important. Think like a venerologist. Venerologists won't say syphilis, they won't say gonorrhea. They will say genital ulcer, genital syndrome, genital swelling syndrome. So we need to write like that. So when a person has got fever, cough, shortness of breath, pneumonia syndrome. If you make a pneumonia, then we need to know what diagnosis is the best diagnostic. Whether without diagnostic I can manage the patients or not. For example, pneumonia, the blood culture yield is not good. So the person is producing some sputum or extraches is more than sufficient. The person has got UTI. In India, UTI always need culture. But patient should have symptoms before that. Patient has got fever, dysuria, urgency, frequency, bladder score more than 4, then we think about it. So these are all the things, depending upon where we are doing the workup, we need to know the syndromes. And with a simple CBC LFT, WBC count elevated or WBC count is normal. Similarly, when the person has got platelet low or not, what LFT pattern, SGOT PT elevated or alkaline phosphatase elevated. Based upon the thing, we can say dengue is there. Dengue means WBC count normal or below normal. Platelet is too low. SGOT is more elevated compared to SGPT, and alkaline phosphatase may be normal. In typhoid, the count may be normal or below normal, but eosinopenia is a marker. In cases of leptospirosis, WBC count is elevated, no platelet, more of alkaline phosphatase, cholestatic picture. In malaria, more of hemolysis. Use the simple rules you can able to find out instead of doing a zombie test of Vidal to make a diagnosis of typhoid in the practice. So the diagnostic stewardship, not only the antibiotic stewardship, we need to know what test to send, at what time to send, what amount to send. That is most important. If you fail to do, you are going to lose lot of antibiotics and kill the patients. Zombie test killing the patients because the diagnosis is delayed. Lot of unnecessary medications can go in. So know which test is a zombie, which test is a real test. Accordingly, you can use it there. So before we start the panel questions, some of the practical points about the zombie, because theory the previous speakers both have elaborated very well. So we need to know what is the best practical points we need to remember. That's also very important for you. I just share a couple of minutes before starting up the thing. 1 second, I just open up the thing. Sorry. So you learned the theory about Ebola so far because both the speakers alluded. I'll ask a couple of FAQ. This is a posters for you. People want to get the certificate today for CME credit points. You need to answer. So first question people want to know, yeah, why Ebola people are discussing now. This is a reason people are discussing now. WHO has announced May 17, 2026. This is a public health emergency. And all the countries put on alert. So why? So this is a last week picture of my taken from most of the hospitals in Chennai there because I go around multiple hospitals. I saw a couple of African patients attending the busy OPD there. So people are saying people are monitored and think there. This couple standing in the tall person standing is a Sudani patient. Sudan already reported cases of Ebola in the past, not now. And couple of patients, African patients, are standing outside one of the hospitals. And third thing is the patient in a busy lift. Some of the patients, African patients, is going along with you without mask also. So this is a last week picture and taken over the city hospitals. So people are saying African patients. I do not know whether they're coming from DRC Congo or whether the person is coming from Uganda. Whether the person stayed in the airport for a long time, whether they mixed with the DRC Congo patients, Uganda patients, I do not know. So what is the real chances of this pandemic is going to happen to India? So people are asking about it. As long as the international travel is existing, this is an international travel, particularly healthcare worker travel, because the commonest point of transmission is in the hospitals and healthcare. So these things has happened. That is why last week this has happened. One of the Ugandan lady got admitted with fever and diarrhea in Bangalore. People got panicked. Similarly, one of the Indian traveled to DRC Congo, came back with fever and cold. Ahmedabad became an alert. This is a Chennai alert. I do not know whether people with fever and cough and cold admitted. I do not know. So this is a real context. So the travel is happening, even though government says government put an alert, don't take any patients from the DRC Congo and Uganda, but still some of the African patients we are getting, hospitals don't want to lose this type of international patients. They want to take the international patients. So the risk is there. Yes, the risk is there as long as the international patients are taking up now. So this is a risk there. So this is an India's response. People put an alert, put an isolation, they did the quarantine, they did everything. And after the two tests were negative, or after the two tests came back negative, then only the isolation was removed. The Ugandan patients got discharged from Bangalore. So the Bangalore was on list. So whether your hospital's on list or not depends upon whether you are taking international patients or not. So the first thing why we are discussing, this is a threat is there, but not a big threat, but threat is there. The second point, people always say, particularly people above the age of 60, during COVID time, they used to call me, Doctor, can I practice now? Even during the third episodes of also people are asking, they put into their practice, they stopped the practice, they went in the virtual mode, somebody said stop the practice also. Now can I stop my practice because now Ebola is coming into the place? What is my practice there? The risk is very low. This is not like previously two speakers alluded, clearly told this is not airborne. This is not airborne, this is a close contact. This is a close contact. So as long as this is not a airborne diseases, and one more point is, when the person is symptomatic, then only he transmits the disease. When the person is not symptomatic, is not transmitting the disease there. So can this be a next COVID? Whether I need to prepare my hospital for a COVID-like preparations, people want to know. Right now, the spread is not great. The number is called R0. That means one person infected with Ebola, how many persons is going to transmit? Is going to transmit 1 to 2. This is not like a measles. If you see the measles can transmit 18%. If it is a H1, if it is a SARS again, initial SARS, that's called 4%. But the diseases that are transmitted by airborne, the diseases are transmitted by the droplet, the diseases are transmitted by before the symptoms, before symptomatic, the risk of having pandemic, the risk of having problem is there. So I don't think so. The problem of getting epidemic or pandemic is not great, but small outbreaks can happen as long as we are taking international patients. Keep in mind, if you take international patients, chances of getting small outbreak is possible, but this is not, the transmission number is not great. And close contact, the one good advantage for Ebola, the person should symptomatic, then only is going to transmit the disease. So the chances of hospital getting positive patients are high. When the person is symptomatic, then only transmit the disease. Before the transmission, before the incubation period, he is not going to transmit the disease to you. Keep in mind. How should I approach a suspected patients? So we need to know the history. Clearly told last 3 weeks history, but most of the patients, they won't tell the history. Please take the history, proper history. Unless you do the history taking is very good. This is very difficult. What happened in each stage of history, fever, cough, diarrhea, vomiting, these are the symptoms you need to keep in mind. So these are all the diseases. So keep in mind. So this is a Buji. This is again the same outbreak happened in 2007. What is the symptoms? This is a common symptoms I told. This is a 2007 paper. If you see fever, fatigue, headache, nausea, vomiting is present. So this Bundi Bugio in 2007 and 2012. This is a common presentations. This is a publications you need to read about it. An African patient shared my OP. So some of the people are smart. I shared OP space with my African patients. I shared the lift with the African patients. What is my risk? Usually, if you don't have a close contact, the chances of getting risk is very less. So this is where we need to do the risk assessment. So what is a high risk exposure? Needle stick injury has got high risk exposure. If you are wearing without wearing a PPE, for example, ordinary mask and less than 1 meter, the contact is transient, the risk is very, very less. This is not a high risk exposure, this is a low risk exposure. So always need to know which exposure is high risk exposure, which risk is a low risk exposure. Know the exposure risk. Unless you know the exposure risk, it's very difficult. Which has got maximum exposure without wearing PPE. For example, ordinary surgical mask, ordinary surgical gown. Examine a patients who visited Uganda or DRC, or patients came from Uganda or DRC, and the person's presentations of fever, cough, diarrhea, you handle without any mask, close contact, the chances of picking is very high. If you sustain a needle stick injury, the risk is very high. So we need to know. Similarly, the dead patient, the viral load is very high. So the bottom line is when the person should have very high viral load, transmit the disease. That's why one of the parameter in the viral load is coming up, threshold, cycle threshold. The cycle threshold is low, the risk is very high. So no risk to worry about. Then people say, what PPI I should wear now? I need to wear again surgical gown, or whether I need to go for a scrubs again? No. Usually this is one of the beautiful picture says, what are the things you're going to do? I said, doctor, what are the things you're going to do? Taking a BP pulse and examining a cardiovascular system or something there. Ordinary surgical glove is more than enough for you. Ordinary surgical glove. Suppose you're going to give a body care for a suspected cases, person visited or some fever or something abnormal presentations, use a surgical gown, particularly the nurses who are providing a body care. Otherwise, ordinary surgical glove with a distance of 1 meter with a well-ventilated room, that is more than sufficient. This is BMJ publications. So what to wear? Ordinary surgical glove, that's more than ordinary surgical mask, not a glove, surgical mask at a distance of 1 meter, that is more than sufficient for most of the things there. Is there any treatment available? The last speaker touched upon it, but what is famous for people? These are all the methods available. So one is a symptomatic therapy. For example, Bundi Bugio, the mortality rate is only 25%. 75% of the patients survive. No treatment used. But how they survive? Good critical care. We have a good critical care team, the patients will go back home. Even if you got Ebola, if you got a good critical time, you'll survive 75% of the time. So what treatment available? Couple of antibodies, we talk about it, but the strains may be changed. But one thing is called remdesivir. Remdesivir, the success rate is 46%. 46%, but they not. In fact, remdesivir was invented for Ebola, but fortunately they changed over to Corona. So remdesivir and favipiravir. Favipiravir, the failure rate is very high, but remdesivir, the chances of success is very high. Chances of success is not great as monoclonal antibody, but almost 50% chances are there. But studies are need to be done. But unfortunately, we are seeing COVID cases again, but remdesivir is not available. COVID is slightly surging. Everybody think about Ebola, Hanta and everything, but COVID is surging again. So that's more important for us. Is there any vaccines? I already talked about the vaccines, couple of vaccines, but any point of time nowadays we got the same Covishield mechanism is available to both Oxford as well as our Serum Institute. Within 2 months' time, we can able to manufacture because they know the thing. And whatever vaccines used in 2015, 2016 epidemic, we can use. The cross protection may be there, but not 100% protections, but cross protections will be there. I have been exposed, any PEP, post-exposure prophylaxis. Yes, couple of drugs, for example, remdesivir, favipiravir tried in couple of post-exposure prophylaxis. Even vaccines can be tried, but remdesivir and favipiravir can be tried. But recent one drug called obeldivir, that has got used for a PEP for post-exposure prophylaxis for corona. That is a oral formulations of remdesivir, almost similar to oral formulations. That has got protections. So we can try that one also. But unfortunately, that molecule is not there. Remdesivir is available, but right now, no company has got remdesivir in the stock right now. We need to think about it. Can I plan my trip to Kenya? Some of the patients ask. Kenya is not in the Central Africa. So can I go to South Africa? Can I go to Kenya? But African countries, always assess whether it's really required. There's an emergency, yes, but need to know how to travel, how to keep safe. That's most important thing. So these are all the practical questions you're going to face. That's why I put common 10 FAQs for you people. These things going to publish in my newsletter. So don't worry about, we can publish in our newsletter, read my newsletter so you can update it there. We can keep the FAQs and questions, whatever you want to do right now, we are free there. So thanks for the opportunity. I thank the organizers, particularly Dr. Nirmal sir and Dr. Sendil sir, for giving this wonderful opportunity. My previous speakers provided the good background for Ebola, and this is a practical thing. I'll put it for you there. I'm happy to, and my team is happy to take a couple of questions there.
Suresh sir,
Yes, sir.
I'm Dr. Sundaramurthy, pulmonologist, student of Professor Devanayagam.
Yes, sir.
How safe doxycycline before the lab report awaits?
Come again, sir. How safe?
Safe for antibiotic like doxycycline we are using left and right.
Even in fact, like a chloroquine and hydroxychloroquine also tried for this like Ebola for a couple of studies there in 2016 and 2017, but the failure rate is very high. So there is no need there. First, we make a diagnosis. In infectious disease, the victim is make the diagnosis first. Unless you diagnosis, don't treat. The diagnosis part is a 90% of it. If you make a diagnosis correct, yes, we can. But if you think the person want to treat, really the person has got Ebola and you want to treat, there is no antibiotic is going to save the patients. If you want good symptomatic care, that's what the evidence is. One of the publications I shown, Lancet publications, good supportive care, good ICU care, the person can go back home. In that ICU care, they mentioned about one of the antibiotics role. My speaker also touched about it, but the person suspected sepsis or suspected infections along with Ebola antibiotic, not routinely. So these things we need to keep in mind, sir.
So regarding fever panel test, is it a must for all fever cases?
I told this is a zombie test, sir. So if you do without making a diagnosis, you need to know what is your top one diagnosis. Whether typhoid is my first diagnosis, leptospirosis is my first diagnosis. Accordingly, you need to ask a test. What is an ideal test? If you think the person has got typhoid, blood culture is a gold standard. But if you got a good lab, do CBC to find out. Similarly, leptospirosis always clinical criteria, modified pain criteria. Strep typhus, search for a scar. So this is what we need to do rather than asking for a fever panel. If you ask a fever panel, that is a zombie. That test you are giving.
Thank you, Suresh sir. God bless you. Thank you.
Symptomatic management suffix side. Yes. The Lancet publications clearly put this is a method. 75% of the Bundi Gunjo patients survived not because of any antiviral, because of the symptomatic therapy.
Thank you, Suresh.
Thank you, sir. Sir, moderator, any questions? I am not able to. Symptomatic management. Yes, symptomatic treatment. Yes, medical infrastructure. We need to have team there. We need to prepare. What government of India and government of Tamil Nadu government is insisting, prepare for it. The chances of going for a pandemic, the chances of going for epidemic is a bit less at this point of time, but we need to prepare because COVID, nobody prepared. That's why we suffered. But this is not COVID. COVID is the airborne. COVID is a droplet. COVID can transmit before the person is symptomatic, and COVID is by casual contact, not a close intimate contact. This is a casual contact. So COVID is not Ebola. It is not going to be pandemic. So far from 1976 to 2026, almost 50 years, mostly it is restricted to the African countries, particularly West African country and Central African country. Whatever cases reported outside Africa, this is because of the medical transmissions. People went for medical supports and everything there in the hospitals or in the laboratory, particularly research laboratory, needed stick injuries happened. They got the diseases in Spain, US and UK. These are all transmitted from the medical cases, not from close in the community. So chances of having pandemic is bit low. How much doses of remdesivir? They say, for example, COVID, we used to give 200 milligram stat followed by 100 milligram. Dr. Namita, any idea what is the dose of remdesivir?
No, sir, not yet. I think the same dose as we use for COVID is what is advised, because they said they'll come with an advisory panel again. So maybe the COVID dose can be used here, sir. Sir, I just wanted to add on. We had Government of India had a pan-Indian mock drill last Sunday. So all the hospitals have been designated hospitals which have been prepared in case we get a case. And we had a mock drill of how real a patient comes, what would be done, even transporting the sample to NIV Pune with a typical 3-layer packaging. Everything was done last Sunday throughout the country in designated medical colleges, and RGGH was one of them to have a mock drill. So in case of preparedness is what. Sir, I just want to tell you, your FAQ slides were not visible. So
Sorry.
if you can run through it, I had also.
Okay, sorry, you had told me initially.
Yeah, I had put it up in the chat, sir.
Oh, sorry, I didn't see the thing because I thought it's visible. For the thing.
Yes,
sorry.
sir. Can you?
It was visible?
Yes, sir. Yes, sir. Now it is visible, sir.
So I just run through it for one time.
Yes, sir.
Everybody knows. This is everybody knows that because the incident of happening there. And this is a reason, and this is a case as what I shown there last week. And one more interesting stuff, the government of India notified on 25th of May to do the mock drill. But couple of Ugandan patients, my knowledge comes to between 19th and 21st or something there, they got fever and other cases. They stayed for 5 days and went home. By the time there's no notifications, there's no mock drill. We do not know how many patients exposed or how many contacts exposed. This is a Sudan patient. Sudan patients still there. So despite the mock drill, I asked the admission counter people, do you ask any travel? Do you ask any fever symptoms? There, nobody is asking. This is a crowded lift there. And this is a Bangalore threat, and this is Ahmedabad threat. People are seeing the Ahmedabad threat and Bangalore threat. And this is a Bangalore case. People keep the Ugandan lady for almost 2 weeks, monitored, did couple of PCR tests, and finally came negative. Then only they got relief. People start using the overalls and everything. This is a Bangalore situation. And can be pandemic. This is an RO number. Usually we keep virtual mode is not required. The risk of transmission to other people is RO, that's called. For measles and other diseases is more than 18. But for Ebola, this is just 2 number. So that's why we need to remember this one. And this is when the person is symptomatic, then only the person is going to transmit. Why this is not going to be pandemic? This is a reason for the pandemic. The person should be symptomatic. Only the person is sick is going to excrete more viruses. Then incubation period or pre-symptomatic, before the symptom starts, the person is not infectious. So that's why we need to know how to identify. So this is an algorithm people uses. Couple of algorithms also available. I just didn't put the algorithm, but this is a Bundi Bujio case studies in 2007 for the publications. So this is a publication data: fever, fatigue, headache, vomiting, abdominal pain with the presentations. The bleeding is very less. If you see the last column, bleeding and hiccups are a bit less compared to fever, body pain, headache. So and one more epidemic in 2012 also the same, almost similar data. I compared the data of both the things. 2007, totally 221 cases of Bundi Bujio already published in the data there. I got the data 221 cases there. And what about the African patients? I travel in the same room. I travel with the live same patients. The risk is, this is called high risk exposure. Person has got broken skin, mucosal membrane exposure, needle stick injury. Yes, this is a very high risk exposure. This is what we need to divide the risk. When a person comes with me there, I share the airplane with the same person. I sitting next to or in the same row. An African patient or sitting, people are asking me there, what is the risk of getting Ebola? I need to do the risk assessment based upon what is the risk of getting Ebola to you there. And this is a risk of infection is very high when the viral load is very high. So we need to know what test to do at what point of time. This is a beautiful paper, again, analyzing thing. And whether PPE, people are keep on asking, this is a BMJ paper, says just distance of 1 meter using a surgical mask is more than sufficient. But people always want to use coverall and overall thing there. But this is a contact transmissions. We need to provide a surgical gown if you are providing a good cover. If you think some splashes is going to happen, we need to wear a face shield. Otherwise, there's no need for a overall and everything that people know. In Corona time, all people are using till 2 years of Corona there. I just stopped my using overall within 2 months of time. And I started seeing my first Corona in March 2020. I stopped using the overall in May 2020 there. So I started using surgical gown, and after 2020 December, I start going with my only surgical mask in the Corona ward. So this is a distance we need to know. And this is any drug existing, people are asking. This is a symptomatic. Lancet publications clearly told 75% of the patients survive. These are all the interventions: oral rehydrations, proper administrations of the parenteral fluid, give some analgesics, staff ratio, how to communicate to the patients, how to keep the patients in isolation. That's more than sufficient. This is a Lancet publications. Read these publications, 2018 Lancet publications. And this is a treatment part. Remdesivir, what is the success rate? 46% is a success rate, not 100%. But monoclonal antibody, the success rate is 88%, 100%. But remdesivir, there is no need for glycoproteins. But for monoclonal antibodies, glycoprotein structures is a difference between Bundi Bujio and Zahar version, Zahar strain. But here for the Bundi Bujio, it's acting on the RNA-dependent RNA polymerase, RNRDP. So it can kill. So remdesivir might work. Favipiravir, the success is not great compared to the remdesivir, but favipiravir, we need to use high. 2000. And vaccines, you already touched about it and not touched about it there. Vaccines are available, and already Oxford vaccine there. And Kenya, people are keep on asking whether can travel. Do, whether essential travel, do, because it's very easy for us to share some of the airplanes. But usually the person is sick. If he's traveling along with you in the airport, somebody is vomiting, somebody is very sick, the person is really symptomatic. That point of time, if you're sitting close to him for 4 to 6 hours, the risk of transmission is possible. According to CDC risk, if you are sharing the room, the person is sick, for example, symptomatic, he has taken some paracetamol and sitting next to you, chances are there. That is why we need to do the risk assessment. really I need to travel or not. If travel is essential, do it, otherwise don't do it. So the take home, always suspect that travel should be there. ID doctors take proper history. That's what more important for us. So we need to take a proper history and handle it there. Unless we do, this is bit difficult for you. Sorry, I didn't know this one. I share it. So this is FAQ I prepared for. I think I'm circulating in my newsletter. It's going to circulate tomorrow then. Last couple of minutes, any burning questions we can answer. Sir, Ebola is a diagnosis of exclusion. Dr. Aarti, any thought process?
No, sir. I think with the test available, I think we need to do the test parallelly, go along with the other tests also. So we need to quarantine when the clinical suspicion and the travel history is there. Definitely, we need to quarantine. Go ahead with the testing before declaring it as not a test of exclusion. People who are living in India will not get Ebola.
So at this point of time, so if the person has got travel, yes, that's more important. But a lot of African patients, most of the hospitals are taking up. So be cautious. Ask these things. So most of the admission counter, what the mock drill we did, I do not know about the Sunday mock drill. So what the mock drill we did, we sensitize the admission counters, we sensitize the OP counter by secretaries. Anybody coming there, ask any history of travel, because we do not know Indians traveling to Uganda, Indian traveling to DRC is also possible. Not necessarily African patients comes to me. Ask any last 21 days travel, any fever, cough, anything. So what I do, ask him to keep in a separate fever OPD clinic. So they can go and sit there, the consultant go and see the patients. Instead of sitting with other patients, I segregate the patients one. So we did PP assessment and we did the downing and doffing drills also we did, and how to clean, because this is an envelope virus. Any agent like alcohol, anything can kill the virus. That's not a big deal here. So all the agents will kill it. Any other questions for the Sandil sir? Anything more from your side needed? Frederick sir? Nirmal sir? We'll share the slides, no problem. Someone want to know the slides. I'm sharing my slides.
So I think we have discussed almost all the queries in the chat box, sir.
Okay. What is the impact of Ebola in pregnant women? Always pregnant, any diseases in pregnant women, it's not going to only affect the individual, but also affect the fetus also. Depends upon what stage of pregnancy. First stage trimesters, possible fetal transmission is also possible. Once the person pregnant and got the disease, the chances of going for severity is always there. For example, Ebola, whoever people died, usually people above the age of 40 and people above the age of 60. So these are all the people vulnerable. Similarly, pregnant ladies also vulnerable. First 3 months of pregnancy, the chances of affecting fetus is also there. I think some gynecologists. Where the test right now, not in Chennai. So clearly, Dr. Aarti mentioned about this is NIV Pune, but Chennai King Institute may coordinate and transmit, or DPH may coordinate and transmit. A couple of transmission circle, you can get the details from the DPH and put it in a notice board, how to communicate, how to transport the sample, everything is available. The DPH has already circulated some orders there. Get the detail from Director of Public Health. N95 mask. Once, if you are doing some aerosol procedure, clearly Dr. Aarti mentioned about if you are doing some aerosol generating procedures, N95 mask. Otherwise, for a casual patient contact, even surgical mask is enough for me, because this needs a close, intimate contact, blood and body fluid exposure. That is more important. So, ordinary surgical mask can prevent you there. If you think the person is going to splash something there, you can use a eye shield, covering shield may be needed. Yes, suspect cases right now we need to send for the Pune only one. We already discussed about the treatment precautions for the contact people. Yes, right now couple of molecules in the US is available, but right now remdesivir, if the companies are manufacturing remdesivir, yes, we can try as a post-exposure prophylaxis, because vaccine take another 2 to 3 months. Remdesivir is the easiest thing we can get it done. We already used it, but the dose is slightly high for here. Whatever the data I gone through it, it is 700 milligram remdesivir. For corona, is only 200 milligram and 100 milligram, but here they say 10 mg per kg, so it comes around 700 milligram remdesivir. That's only concern. Yes, symptomatic meaning sufficient. Lancet paper clearly told that, sir. Yes, thank you. I think almost all the things we gone through it.
Yes, sir.
Still 450 people are there. Thanks for participating and thanks for allowing us to do a wonderful presentation. I thank my co-speakers also for the Wonderful talk, because only I put the FAQCC for you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thanks for the opportunity.
This is Dr. Ibrahim, Joint Secretary, IMA TNSB AMS chapter. So on behalf of AMS, our sixth CME of this year, that is in the month of June, has concluded. So we had a very nice discussion, lively discussion, and very informative discussion on Ebola virus, and also about the zombie test in various infectious diseases management. And all the three speakers did wonderfully well, and all the informations are very much worth. And you can see the number of delegates are almost 480 plus, and we had peak around 550 total. And there were about 1,000 registrations for this meeting, this online CME. I thank all the three speakers, Dr. Aarti, Dr. Namita, and Dr. Suresh Kumar for their wonderful presentation with eloquent presentation with the slides. It was very informative and easy to remember for during the clinical practice. On behalf of AMS, we thank the IMA TNSB State President, Dr. Sridhar sir, for giving us this opportunity, the State Secretary, Dr. Tirve Mohan, and the Finance Secretary, Dr. Solomon Jaya, for attending the meet, and also past President, Dr. Sir, who participated and gave the valuable note, Dr. Sengutwan sir, and also Dr. NRTR Tyagarajan, our President-elect, who encouraged us with his golden words. And I also thank all the delegates who lively participated and participated in the discussion, also post-presentation. And I hope we'll have some other interesting topics in the next month. And I request all the members, there are some members who are non-IMA members who participated in this CME to become members of IMA, so that they can become members of AMS also, so that they can participate in various academic programs and also participate in other fellowship programs by AMS. And once again, thank you all for the wonderful online CME. Thank you. Thank you, madam.
Thank you, sir. Thank you, sir.
Thank you, sir.